Guys, we're in the middle of the pandemic and these are trying times. It's hard on our mental health, our mental state. And this is why I love our sponsor today, BetterHelp. They're the largest online counseling platform worldwide. They change the way people get help with facing life's challenges by providing convenient, discreet, affordable access to licensed therapists. BetterHelp makes professional counseling available anytime, anywhere, through a computer, tablet, or smartphone. It's brilliant. Sign up today. Go to betterhelp.com/solvinghealthcare and get 10% off sign-up fees. Welcome to Solving Healthcare. I'm Kwadwo Kyeremanteng. I'm an ICU and palliative care physician here in Ottawa and the founder of Resource Optimization Network. We are on a mission to transform healthcare in Canada. I'm going to talk with physicians, nurses, administrators, patients and their families because inefficiencies, overwork, and overcrowding affects us all. I believe it's time for a better healthcare system that's more cost-effective, dignified, and just for everyone involved. Quadcast Nation, we're doing it again, people. We're doing it again. We are getting some of the brightest minds when it comes to infectious disease, public health, to come out and talk to us about all things vaccine, all things variants. Is there going to be a third wave? Some of y'all might have seen me on the show busting out why I don't think a third wave is happening. Maybe someone on this panel will contradict what I had to say, but listen, these are the brightest of the bright that we got in the mix. So number one, before getting into it, I just want to say thank you, Zain, Chagl, Sumon, Chakrabarti. Welcome to the podcast as usual. Thank you. And couple housekeeping things before we get started. We have beautiful content that comes through our newsletter. So if you guys want to be able to get our health tips, latest podcast ideas coming through, just type in news in the text box, and you'll get the most recent and latest information from the Quadcast Nation. If you like what I'm wearing, solvinghealthcare.ca/shop. Got all our merch, got our seminars, all in the mix. So yeah, don't hesitate to check that out. Last thing, despite this being an all-male panel, I'm going to address it straight up. I'm going to do straight up. Happy International Women's Day. We got Julia helping out, thank God. But I just want to give some love on a special day like this, where there's a lot of the better halves out there that have contributed so much to science, to the arts, to whatever, to all. And we're forever grateful. It's a great day to celebrate. So thank you. All right, gentlemen, should we just dive into this bad boy? I think, you know what, I'm gonna start with Zain, because I feel this is a sophomore jumping in the mix. So
he's also way smarter, so that's good. So then I can go afterwards and just copy what he said, or the other way around. I can go and he can show me up, whatever you want.
Fair enough. I think I'm gonna leave this a little bit open, actually, Zain. There's a lot of hype with the vaccines. There's a lot of concerns. There's a lot of excitement. Without putting words in your mouth, why are you excited about the Canadian vaccine situation?
Like, it's March 8th, right? Do you remember March 8th last year? Do you remember?
I do not want to.
I think it was, I want to say it was March 10th. They did that Utah game where Rudy Gobert test positive. I had Lakers tickets the next week, and even in my head, I'm like, this does not seem like a great idea going forward. But anyways, Rudy Gobert test positive, NBA shuts down, everything shuts down 3 days later. I think of that day a lot, right? And I think of that week a lot, because it was like, you knew this thing was going to be here for a while. There was nothing we could do about it. It was spreading all over the world to every corner of the earth. It was hitting our hospitals. Yes, we talked about vaccines, and I think Pfizer was just doing a little bit of that pre-work with, and BioNTech with mRNA vaccines. But we're talking a year later. We're talking about a rollout plan of 4 different vaccines It's just incredible. Like, can you think of this? Like, a year ago, we had no clue how this pandemic was going to end. We had no clue if we can even develop a feasible vaccine. You know, the only model of respiratory tract infection vaccine we have for a virus, you know, is influenza, and that's not a perfect vaccine on its own. And now we're talking about 60 to 90% effective vaccines that stop hospitalizations and deaths, vaccines that can be administered with as little as a single dose. I mean, this is where the excitement is, right? Like, we have essentially used human ingenuity and science to actually get our way out of a pandemic where 100 years ago, it would just rip through humanity. That would be the solution, right? That would be the only thing we could do. You could do it fast or do it slow, but it'll rip through humanity. And now we're talking about, you know, again, a vaccine strategy. It hasn't been perfect. We don't have a great supply. And I think, you know, at the end of the day, we're Canada. We're not a manufacturer. We're not the EU. We don't have a block. And so we're, you know, we have contracts for vaccines. We'll get them as we come. And it might be a little later than the other parts of the world. But we're getting people vaccinated. You know, if you look at what's happening in long-term care, like, it's incredible. With the amount of COVID we have in our community, long-term care should be a disaster right now. And we're talking about less than 200 cases in long-term care, which is unheard of at this point in the pandemic, right? And so, yeah, this is just proof of principle. These vaccines are potent. We're getting them out. We're getting to the right people. We have a lot of supply coming in over the next few months. You know, things are looking brighter by the day. And again, I would pray for this moment last year, even if we have vaccine rollout delay. I would pray for this moment last year.
That is so well put. Like, in terms of putting it into perspective, a year, like, I remember for me, like, it was more the clinical side, like being in the ICU. We got our first patient wheeled in about, I want to say the 17th-ish of March. And how fearful, how scary that was, and how our lives completely changed. And there was no clear hope in sight. You know what I mean? And now we're where we are today with the vaccines, with 4 approved in our nation. God damn, it's a special time. It is a special time. Sumon, let me ask you. So a lot of hype and chat about, you know, people having concerns about efficacy in terms of one vaccine versus another. And you know, Zain touched on it a little bit, but what is kind of like your approach or advice when you see people are like, damn, I don't want that AstraZeneca, you know, it's only 68%, you know what I mean? Like, it's like, I'm going to hold out. I'm going to hold out for the better ones. What thoughts come to mind?
Well, this is actually something that I'll admit that I've talked a lot with Zain, Dr. Chagl here, and Dr. Bogach. It's just to inform the opinion is that when you look at these trials, right, they were done in very different times, different circumstances. Some were in areas where there's lots of variants, some in areas where there's lots of infection, others where it was a time of the year there wasn't really as much infection. The point that I'm trying to make is that there are kind of different. It's a bit of more of like a apples and oranges situation. So what I like to do, and you know, a simple guy. I'm not an academic guy. I like to try to compare these things right now for what we need in a public health emergency on an even playing field. What do they do for me for deaths and hospitalizations? Okay. And, you know, I know this is not exactly 100%, but they're really, really effective in the trials showing that, look, there's essentially nobody in all 5 of the vaccine trials that we have, including Novavax, where there was not one person or maybe one person hospitalized and there's no deaths. Now, I know that's not going to be perfect as all the data comes in, but even in the real world, what we're seeing happening in Israel, what we're seeing happening in the UK, it's unbelievable. Okay. And something that, you know, we thought that something like 50, 60% efficacy would be what we would be jumping at. We're seeing way better than that. And I think that we've all been talking at some point thinking, look, we're not ever going to eliminate this thing. If we can get this thing to a point where we turn a major disease into either nothing or something minor where you don't have to get infected, that is our ticket out of the pandemic. And I want you guys to groan at this next line. We have the answer in our hands. We need to now get it into our arms.
Oh.
Terrible dad joke, but
oh
dad
my
jingles,
God, your
man.
kids must be screaming.
Oh my God, his kids are bleeding.
I'm single now, by the way, so just
Oh my God. Oh, you're gonna get me off my game. Yes. Okay. Yeah, in terms of efficacy, I like the point in terms of metrics that we need to be considering here. Like, because once again, in amongst, I think what I've seen, 70,000 studied, I think one patient in the Moderna trial got hospitalized.
Yeah.
Like, that's insane. And then when you, as you said, you look at the real life data, UK, Israel, like it is showing the vaccines are quite effective. So when it comes to maybe Zain, I'll hit you up. When it comes to like just being as upfront with it as possible, AstraZeneca, and there was a lot of concerns with NACI, for example, not offering that to our elderly population. Any thoughts on that in general when it comes to AZ?
Yeah, I mean, so recognizing that the AstraZeneca trial didn't enroll as many people over the age of 65 as the other trials. And that is the major difference here. They enrolled about 6,000. They kind of combined two trials together. They had a couple of hundred individuals over the age of 65. And none of, or very few, I think zero or one of them ended up getting COVID in each arm, the placebo or the vaccine. And so it doesn't mean that the vaccine doesn't work. It's just you didn't have the numbers to really show an effect there. If you had 2,000, if you had 20,000, you would probably start seeing that difference right away. The phase 2 data suggests that, again, T cell, B cell responses are actually pretty good in 65 plus year olds. And again, there just is not the clinical data there. And so I understand where NACI came from with that statement to say, okay, looking at the clinical data, the most robust data we have at this point, we just can't make conclusion is efficacious for 65-year-olds because there's just not enough of them in this trial to make a conclusion. But the big advantage of this vaccine is one country has taken a gamble on it and published its experience. And in fact, us as Canadians are benefiting from that experience, right? The UK took this gamble. The rates are out of control. Things are going crazy. And so, they said, we would rather just get people vaccinated and figure it out over time rather than necessarily, getting to the perfect vaccine over time. And so, a good study from Scotland looking at first dose vaccinations as compared to a historical control, Pfizer and AstraZeneca, you actually see the AstraZeneca vaccine in those individuals actually outpacing the Pfizer vaccine after the first dose. You see 3 hospitalizations after day 28 after someone gets an AstraZeneca vaccine as compared to the historical control, which is huge, like up to 94% efficacy. You also have another trial out of the United Kingdom where they look at first doses, particularly amongst elderly individuals. You actually see less symptomatic COVID-19. So the one thing that we critique AstraZeneca because symptomatic COVID-19, that 67% or 62%, you actually see that number getting closer to 70-ish%, which is higher than Pfizer BioNTech after the first dose in the UK experience in the elderly individuals who get this vaccine. And so I think there is enough real life data emerging to suggest this is an effective vaccine. We've seen governments like Germany and France pivot and say, actually, considering that data that's coming out, it looks comparable to Pfizer BioNTech. It's not even like it's a grade lower. It is actually comparable, if not better, in some of these trials for 65 plus year olds. And again, I think the big elephant in the room about this vaccine is it is fridge stable. And so the requirement to get it out there into family doctors, pharmacies, arenas, homeless shelters is so much more potent. It is, from a side effect profile, actually a little bit less than the Moderna and Pfizer vaccines, in the sense that less of that, sore arm, sore muscles, that type of thing is part of it. Again, this is the vaccine that much of the world will use. And I think we have to recognize that. Like, we in Canada, we're fortunate. We probably will have 5 vaccines coming to the market. Much of the world, much of the low and middle income world particularly, will be an AstraZeneca fueled world in terms of their vaccine strategy. And I think, again, it's going to be efficacious for them, and it's going to be efficacious for us to use it in that sense. So I don't have any doubts this is going to be an effective, not an effective vaccine in over 65. I think it will be. actually good clinical data suggests, dose delays for this actually probably improve this vaccine. So that day 90 post-vaccination is probably the most optimal strategy for this vaccine, which is fantastic because you can give doses out quicker. And again, the safety profile, the refrigeration profile, like this is a good vaccine. And in real life, this might perform better than some of the other vaccines we think are better in that sense.
It's unbelievable. Isn't that amazing though? Like that narrative or that aspect of real world data hasn't really come into mainstream media. Like when you it was news to me. Like for those that don't know, well, everyone doesn't know. We're all in the same kind of like chat group, and the amount of anything you hear me saying on the news is based on this chat group.
I feed him bad stuff, like bum steers and stuff.
Absolutely. But like when you, looking at the UK Scottish data and seeing actually like single dose can have improved outcome relative to Pfizer using real life data. Like and then we're going to say, obviously, as you put it, based on the studies, which is underpowered, I guess, for looking at elderly patients. This is why it was not recommended by NACI. But once again, these details aren't really, you don't see them in the fine print. You don't see them in the news. And this is why I think this platform is good to be able to express it. You don't have to be cut off after 43 seconds. You know what I'm saying? Sumon, what do you, like your personal thoughts on the delayed strategy for vaccinations, i.e. normally, I mean, I got my Pfizer 3 weeks apart, you know what I'm saying, as per study protocol. Now we're going to be busting that out 4 months gap potentially. What is your thoughts on this strategy?
So it's kind of twofold. So I think that first of all, I like the idea of getting as many first doses out as you can. So like if you got 100 people, I think it's better to have 100 people that are half protected as opposed to 50 that are fully and 50 that are completely unprotected. From the point of view of public, like population health, trying to kind of break those chains of transmission, I think that's the way to go. Okay. The second thing is that my mentor Jay Keystone, he was a big vaccinologist. As it was kind of his minor, if you will. He used to always talk about there's a very, very big precedent for separating vaccine intervals. So just to give you an example, hepatitis A, you can go anywhere from 6 to 36 months for the second dose. So the idea, the way vaccine immunology works and the memory response, sometimes going longer actually strengthens the response. Now, of course, the other caveat is you don't want to go crazy and kind of start doing 36 months with the dose. You want to stick to the trial. I think that we have data up to 3 months. I will be honest with you, and I'm not a guy that trashes people that are things that I don't agree with, but I will say that the 4-month thing surprised me because it just kind of came out of the blue. It's like, we talked about 9 weeks, or 6 weeks, sorry, we talked about 12, but all of a sudden it was 4 months. And now everybody suddenly moved towards that. And the reason that bothered me is because the initial thing from NACI that came out about AstraZeneca, they didn't want to use it in 65 and older because of lack of data, right? That was their position, which I also didn't really agree with, especially with what was going on in UK, in England and Scotland. But then here, you don't really have that much data. There might have been a model, maybe a mathematical model to go with that 4 months. I'm not completely sure, but I'm noticing, at least in our province, they said up to 4 months, but everybody's going to 4 months, right? I suspect it is a supply thing, but I think we just have to be careful about just straying too far off the trial. So I think it is great to get as many first doses out as possible. It's great that we can feel comfortable with somewhat stretching the interval, but I think we should be careful about going too much outside of the trial.
Fair enough. Zain, I saw you had a thread on this actually that I found quite informative. What were your thoughts?
Yeah, I mean, so I think Dr. Sumon got it right? Like we have 2 to 3 month data. You're explaining month 4. It might be a bit long, but I think it's probably a delay that's offerable. We know vaccines and that memory response, the boosting response is not something that just disappears like that. There is a buffer where boosting actually works in that sense. I think that concept of getting more doses out there. So again, if we had perfect supply right now, if there were 72 million doses of Pfizer vaccine coming in tomorrow, I would say 100%, let's just go with the full strategy of 3 weeks and then come back, right? Because we have 72 million doses, you do everyone, that's fine. The reality is in the next 4 months, we have 12.8 million doses of Pfizer. We have a few million doses of Moderna and a few million doses of AstraZeneca. So enough for maybe 15 million people in Canada. There's 30 million people that are probably eligible for these vaccines, given that we can't give them to under 16-year-olds. Which means we have a choice here, right? Do you actually work to get 7.5 million people fully vaccinated, leaving a vulnerable 3/4 of that population out there? Or do you get 15 million people partially vaccinated? It's not perfect. There will be breakthrough infections and hospitalizations because, again, you don't get the full immune response. But if you do slow chains of transmission, you do create some more herd immunity within the population, which will have rippling effects in terms of protecting everyone. So if the general baseline risk in society is low, then you also have, positive effects on every individual, even having a partial response. They're protected from the rest of society as well. And I think recognizing that, again, right now we are struggling with hospitalizations, we're struggling with deaths. And so if in that context, you get less hospitalizations and deaths coming into the next 2 to 3 months, that is going to help our system move forward. The last part is, listen, this is probably not the last vaccine people are going to get for COVID-19. I think, with variants of concern, with the need for probable boosters, with need of pediatric immunization strategy, we will probably see 1 or 2 or 3 boosters in our lifetime in the next little while. We know that Moderna and Pfizer, their boosters will not only boost our response to the immune escape variants of concern, but they'll likely boost the native response to COVID-19. So anything we may lose kind of with that delayed strategy, we probably will gain back over time. The nice thing is hopefully when the dust settles, then we're not talking about hospitalizations and deaths. We're just talking about updating our vaccine so that we, have the most robust response for the next 5, 10, 15 years. So again, they're risks, they're calculated gambles. It's not the perfect scenario. And again, the perfect scenario is having vaccines like the United States where things are rolling in. But this is kind of a compromise saying this is what we have. These are the tools we have for the next 3 months. What can we do to change our pandemic as much as possible? And I think this is the strategy that is as close to as optimization as we can.
And yeah, I have to say, and I didn't think I'd ever say this in this context, I'm a little bit envious of the States right now. They've vaccinated 90 million people.
It's insane.
It's insane.
If you think about it, it's like the Israel of the West or something. You know what I mean? Like boom, just like that's my vaccine sound effect, by the way.
Vaccine rollout.
Yeah, I mean, essentially that's what's happening down south, and it's impressive. Yeah, honestly, I think it's a natural transition into variants here. Trying to think of how to frame this. Maybe we'll start with Sumon. There has been a lot of fear based on the variants of concern, more contagious. Sometimes you'll hear our leaders say it's more deadly. What is maybe your general, leave it open, like your general sentiment when you hear us talking about variants of concern? Like what comes to mind? Like you start getting palpitations? Do you start wanting to cry in the corner? We're looking for a whiskey sour. Like what is it? I don't know why I went with that. But yeah, what are your thoughts?
No. So this is the thing that I think was when the variant, if you remember, before B117 was mentioned in December, there was another variant in the UK. What was it again? I forgot the name of it. D something. It was like in September.
D614G.
That's the one. D614G. Right. Thank you. So the thing is that I think that those of us who are in ID, the idea of a virus varianting is something that's very, very well known. So the fact that this was happening was not surprising. But yeah, like there was some concern that, look, the secondary attack rates and a lot of these clusters that they were seeing in the UK were suggesting that this looks like it might be more transmissible. The thing that's always bothered me about the variants of concern, and I'll tell you. So first of all, for the record, I respect them. I'm not saying to open up and have concerts. I'm just saying that we took that information about them being transmissible at a time in England when they were having this surge in December, which many Western Christian countries had because of Christmas get-togethers. And you see that, not all of them, but so many of these countries had this spike in December and it came down precipitously in January. The only thing that I'm trying to say is, could there have been something in there that was confounding this transmissibility? Okay. But even if that's the case, you then move on. I think that what's been happening is people are saying, okay, this is more transmissible. So that automatically means that there's going to be more viral transmission. And what bothers me about that is that there's much more to viral transmission than just transmissibility. So for example, rhinovirus is extremely transmissible, but you don't see the rhinovirus like raging in July in Canada. And the reason is there's other factors that result in viral transmission. And I think that what was happening, and with all due respect to my colleagues in epidemiology, it felt like the number was being plugged into a model and it was giving this exponential wave, whereas it wasn't taking into account the fact that we were moving into the springtime. There's vaccines rolling out. There's also certain areas, like I'm in Peel region in Mississauga, Ontario, where there's already been we've been really hard hit. So there has to be some level of population immunity that would at least blunt things. And what I'm trying to say is that at least with B117, I suspect there's more to the story. There might be a bit of a swell in the wavelet. I can't see it being the same as the second wave. The second thing I'll say, I won't talk too long, but is the variants of concern of their escape mutants. The thing that bothers me about that is that, yes, in these kind of snapshots in time when they took people's serum and they found neutralizing antibodies, there's a comparatively lower level of antibody. Okay. That makes sense. But the thing is that that's kind of a snapshot in time. It doesn't take into account the memory response. And it also doesn't take into account what the T cell response can do to the virus. So the other interesting thing is people leave out is even in, for example, Johnson & Johnson, even with variants in South Africa, the hospitalization rate for severe disease was still very, very low. Do I think we're going to need a booster like Dr. Chagl? I keep calling you Dr. Chagl. Screw you. You're Zain. What Zain said. Zain, I think Zain's absolutely right. And so lots of virologists have been saying that we're going to have a booster at some point, right? We're going to need it. But is this going to hinder our current campaign of getting out of this pandemic with this vaccine campaign? I don't think so. So that's my thing. I have respect for it, but I'm just having trouble picturing it exploding. I've never seen except for last year when you had a whole bunch of March break cases come back. I can't see a respiratory virus exploding in March, April, but I think caution is the way to go.
Yeah, I think.
Yeah.
Sorry, go ahead, Zain. Yeah.
No. I mean, I think Sumon puts it so well, right? Because I think, we described these VOCs based on a reproductive rate, right? And I think that got ingrained into us as if you have a single case, you have a reproductive rate, therefore your reproductive rate as a society changes when these cases show up in society. But, we know from epidemiology, it's much more than that, right? It is, the epidemiologic triangle. It's the host, the pathogen, and the environment, right? And so, yes, you've changed the pathogen factor. One of those points on the triangle has changed. The pathogen may have a higher viral load. It may have a better affinity for respiratory tract receptors. It may have a prolonged course of shedding, one of those features that leads to more transmission. But the host and the environment aren't necessarily reflective of the aspects in England at the time of transmission of B117. So you kind of had the right epidemiologic storm. You had a point in time where people were reopening, where bars and pubs were filled, where London itself proper was kind of where we are at stage 2 last year in that sense. Where you could go limited capacity into certain places where people are getting together, and rightfully and wrongfully so. And again, you had the host, which was a vulnerable population that was not immunized, where you had zero kind of baseline immunity, even in kind of the vulnerable sectors, nursing homes, da 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 da. And so, you led to this perfect storm. The problem is as we come up with epidemiologic estimates of what this means translated into other societies, we certainly have this pathogen replacing current pathogen because it is more fit and more transmissible. But from a population standpoint, it's hard to bake all of those into a single measure when our society is so different in that sense. We're still distancing. We still have capacity limits. We still, I think most people after Christmas, whatever happened at Christmas, but people, have made their choice. We still have big vulnerabilities where this can explode. And I think we definitely will have problems there in homeless shelters and in workplaces and other congregate settings. But I think if you bake it all into a single epidemiologic marker, a reproductive rate, and then we just apply it universally forward, you get into trouble, right? And it doesn't describe the epidemic as well as it should. And I think that's where this, I think a lot of people are critiquing the modeling that came from the federal government a few weeks ago, where you saw that figure where the cases just went straight up like that. But that's really the problem here is you take a homogeneous model of exactly what this does, you bake it into one epidemiologic statistic, and you just let it drive and see what happens. And again, that's not necessarily the complexity of real epidemiology at this point. It's a good estimate, but again, you have to put those assumptions in there that we act exactly like the conditions in England at the time when this kind of explosive growth happened. We had no vaccines. And again, we have a vulnerability across all sectors in that sense.
There's two things I gotta add to that. One, when it came to one of the, I forget the source and I apologize, but when it came to the South African variant, I thought I saw some data that was making it clear that it's not necessarily more transmissible. Yes, it was, it was consistent that there was decrease in casing in South Africa, but shoot, I wish I had the source. Ignore that if you haven't seen it. Second is, can we just take a quick comment on the modeling though throughout this pandemic? Are we allowed to do that? Are we allowed to comment on this bad boy? Like, I know Zain, you hit that up a little bit, but my God, you know what I'm saying?
I mean, we're not modelers, right? Like, I think we understand where it comes from. Modeling is a tough science, right? And I give it to the people that do it. You have to make assumptions on real world conditions that are often really, really difficult to make, right? You have to make assumptions on what workplaces look like, what susceptibility looks like, what exposure looks like, what adherence to public health rules look like. And again, there are so many features of a model which are so hard to tease out, right? Like behavioral interventions. So if we institute a lockdown and then people decide not to get together because society has instituted a lockdown, how do you separate that into the model? Because if you put that in, you say, well, the lockdown and the fact that capacity limits were so reduced decreased transmission. Well, is it that, or is it because, again, everyone said, oh God, this is serious, we got to stop getting together. That type of behavior really locks down. And that's really what is baked into that figure. And so again, modeling is a tough science. You never want to be right with these models, especially if they're catastrophic. And I give people credit for the ones that generate it. But I think we are such a data obsessed population now that you also, when you're displaying this type of modeling data, you have to display the assumptions. You have to tell people why you came to that conclusion, right? It's not like March where people didn't understand this type of modeling. People are hanging on every word, on every diagram, and basing their lives and their future predictions on it. And so you have to tell them what those assumptions mean and how you got to them.
And affecting policy, affecting our lives, based on some of these, the projections, you know what I mean? Like, we are going to put in these amount of restrictions based on how things are looking. So yeah, I mean, you gave a much more politically correct answer than I ever would at this point, just because I do get a little bit frustrated that, I think what would make me happy actually, Zain, that you expressed is the like adding the assumptions. What is being assumed in this model? Why it might have it's been so off based on, you know, like I could see where the assumptions may have gone wrong. Okay, I'm gonna leave this one open. Actually, I'll go with Sumon first. Do we think a third wave is happening, in your humble opinion?
Yeah. So, of course, I have no crystal ball. I think that with obviously it's not exactly going to map on that, but I think that what we're seeing a lot here happening is kind of like the strain replacement. And I'm sorry, my microbiology friends and virology friends, for saying strain, but like a strain replacement that kind of happens at the end of the season with flu A and flu B, right? And we often get that. I do think that we're going to have a swell in cases. I think that we might see. I've been calling it a wavelet. That's what I expect. That's what I can see happening. The one thing that I'm also very adamant about is that we've been looking at a lot of these numbers. And one thing that I think that the numbers are starting to become much less relevant. So first of all, we have vaccines happening. It's slow, but it's happening. And we have LTC covered in Ontario now, right? So now you have a whole bunch of numbers that are there of people that proportion of people getting hospitalized is not going to be as big. And we have to remember, why did we do any of this, any of these restrictions, any of this? It was to slow community transmission so that the hospitals in that region don't get overwhelmed. So if we're getting to a point where we have a vaccine that reduces people from getting hospitalized, right now, I mean, we're obviously not there at the end yet, but right now we're in a transition period where now less people are going to get hospitalized. Less LTC in my region is going to get hospitalized now by virtue of the vaccine. So I think that we need to start moving away from this daily case count and looking at other metrics. And that's tough because now it gets nuanced. And I'll point out one more thing is that the numbers are going up. Okay. I mean, I guess today was a bit of a mistake, but there were a couple of days that there were 1,200 or whatever. But the thing is that there's also sweeps going around looking at outbreaks. There's a big outbreak in the homeless shelter in homeless shelters in Thunder Bay, in Toronto. There's one in Lambton County in Sarnia, where I'm from. So these things affect the numbers. But if we do a lockdown in Peel, what's that doing for the homeless shelter outbreak in Thunder Bay? Nothing. And I think that's what my frustration has been, is that when the numbers go up, everybody wants to lock down, and that's not necessarily the problem. And I think that we need to have a more precise way of dealing with this thing.
I love it. Precision, because I mean, I know it's not politically correct. Maybe I'm just getting more brave here, but it's lazy. I'm sorry. The lockdown is lazy. And it's because we're not getting to the root cause. You're not getting to the root of the problem. And we've talked about this many times. Like when we talk about essential workers, when you talked about initially, especially in that first wave LTC, like that's what the locking down ain't dealing with the main issue, the main source of the problem. But I do agree, though, we do need to emphasize get away from cases, because once again, we are vaccinating our most vulnerable, and they're the priority. They're the ones that we see in ICU. They're the ones that we see in hospital. And so that's going to have, in my opinion, a humble impact on how things end up.
Kwadwo, can I add something to this?
Yeah.
One quick thing I wanted to add is that this is a crazy thought that I want to kind of suggest to everyone, is that right now we're doing community testing for COVID because we need to know what's happening in the community where we are in the pandemic. There will be a time very soon, and I'm talking about this year, where we won't have to test the community anymore, because we know that whatever's happening in the community, we don't need to know, as long as we're monitoring what's happening in the hospital. Mm-hmm. And that's what happens with influenza every year. So influenza, we know that around the wintertime, whatever it is, whether it's November some years, it's January some years, we have a spike in cases, and we know that at the hospital we have to hunker down. We don't close the community when we have influenza spikes. We don't start testing the community in October, November, and see numbers going up. We just see it in the hospital and deal with it. And that's what's going to happen with COVID as well. And one thing that I'm really interested in seeing, I'm already seeing people talking about fourth wave. But when COVID becomes more of a endemic type thing, I wonder how viral interference is going to start to play, where influenza is going to say, hey, you're on my turf. What are you doing here?
Mm-hmm.
And then just kind of compete with it. So it'll be a very interesting.
I'll put that out on the group. I thought it was a little bit voodoo. You know what I'm saying about the viral interference, because it was crickets when I threw that out to y'all.
Oh man, but the thing, we see it, right? Like, why one year is H1N1, pandemic H1N1 high, and then other years is H3N2, right? There's fact, and they constantly compete with each other.
Yeah, because honestly, it doesn't make. I don't care what you could mask. You could triple mask everybody on Earth. It still doesn't make sense that there's no relative influenza going around and can't, like, in the world. Like, I can't think of a hospitalization with influenza positive in our area, but I'm sure there has been. But you know what I mean? Like, that's to me is crazy.
Have you guys seen any? I haven't seen
a single one.
I
haven't even heard of a single one. You guys are ID cats.
There was an article, I think I was reading, that the Public Health Agency of Canada can't declare the start of influenza season because there've just been so few cases.
It's crazy. Like, I thought I saw the citation where there's been like something like 9 cases in the country, and I'm too afraid to like bust that out because I'm not. Well, I just did, I guess, but because it seemed too crazy of a number. But like, literally, there's no influenza. Like, that's and you'll hear people be like, well, you'll see the effectiveness of hand washing and masking. I'm like, still, there's times where people aren't doing that. You know what I mean? And so, like let's get real. Like, there's going to be 1 or 2 cases that creep in there, you would think. So there's something more happening. Anyways, all right, Zain, your opinion on third wave. Do you think are you anxious? What do you think? What do you think is going to happen?
Yeah, I mean, I think we talked about this, and the 3 of us have even written about this, right? Like, there are still vulnerabilities, and like it or not, as people start gathering, as workplaces start opening, as there is a little bit more transmission, and with variants here, and I don't want to necessarily throw that they aren't going to transmit, they are. And they seem to have vulnerabilities in densely populated settings. There are vulnerabilities in workplaces. There are vulnerabilities in jails. There are vulnerabilities in shelters. There's vulnerabilities in other congregate settings that haven't been vaccinated. And like it or not, yes, lower community transmission helps protect those places. It's not perfect, but it does have it. But it's not trickle down. And so those controls aren't in place for a number of those settings. And I think Thunder Bay is a great example. I've worked in Thunder Bay for 7 years, and I know that community is a huge amount tied to Indigenous reserves, the jails, and the scarcely housed setting downtown. And to see COVID get into that setting, it is disturbing, because it is such a fragile environment with such mobility, with such mental illness. And again, none of you can lock down Thunder Bay tomorrow, and they did, but again, it doesn't necessarily quell the transmission in the setting when people aren't housed properly, when jails aren't staffed properly for this type of outbreak. And again, all it does is, when community transmission gets higher, the settings become tinder pots. So, I think as we start getting vaccine rollout, as those people start getting vaccines, you start dealing with vulnerabilities. But I do have a little bit of pessimism over the next month or two. Those settings are going to be lit up, and it is going to lead to more transmission, and that's going to look poorly. And there are going to be hospitalizations from it in that sense. So I think we are going to see transmission. It's not going to be as profound as the long-term care deaths that we saw in this wave. But I do think we still have a lot of vulnerabilities as a society. When community transmission starts rising, we unfortunately will see those settings hit the hardest as part of it.
Isn't it amazing though? Like, to this day, we experts like yourself, Zain, Sumon, you've heard Steph talk about this endlessly, Steph Burrell, how we know where the problems are, and we still aren't coming up with the solutions to address them. It's almost like it's insane, actually, when you sit there and think about it. You have the experts in the field that's seeing it in real life and how it plays out, and you could scream it from the rooftops, and we still are not getting to the root problem. It's hard to see, and I hope we do a better job in the future. We did a little thread on like lessons that we hopefully learn from this moving forward for the next,
That was a great thread, man.
Oh, thank you.
Yeah.
But it was funny because Angie Seth asked me this question on was it Sunday, whatever, yesterday, and I'm like, thank you for asking me, but I'm like, I normally would give an 8-minute dissertation on this, and I had 45 seconds, so I had to hammer out maybe 3 things, but it was actually
well done. It was very well done.
Thanks.
And I'll give you one anecdote, and I think this one hurts, right? Like there was an individual who's scarcely housed that, as part of his healthcare team, didn't want to get vaccinated. And it was, there's an outbreak ongoing. What do you need? What more proof you have friends and family that are COVID? And the answer was, this person was being put up as part of the city housing in a hotel. And his answer was, listen, I get vaccinated, the pandemic ends, that's great for all of you guys. My housing disappears. And I go back to going to the streets, right? It is, we've done a lot of things temporarily to support populations. I mean, I think we've done a lot to help certain populations. But if we don't take those as permanent solutions, if we don't work towards housing for people who are scarcely housed, if we don't work at workplace safety for some of these plants in Peel region, we just did things temporarily for a pandemic. We didn't learn our lessons from it, right? And I think that one hurt me a lot. That one really was profound to me, to say, okay, you guys are worried about this pandemic. I'm worried about where I'm going to sleep after this pandemic. Yeah,
and I mean, honestly, Zain, if you're going to 80-20 health in general, like if you're going to have an approach to really like an intervention that will have a monster impact in the patients and in patients, is having housing, like period. Like that, if you address that full on, and then you realize, when you think about the resources we've used to address COVID, like if we just focus some of that, even a small portion, on making housing a reality for many of our Canadians, I think we would actually get a return on investment, actually. Wow. So people, this is your opportunity to ask your questions. I see that we have a couple questions that made it through. The wonderful Julia Hajar, who is our #1 social media lead, or essentially like the leader amongst leaders in our group, and has an amazing website, A Spoonful of Science. You should follow her. Leave links in Julia, you should make sure to leave links in the text box. Has curated a couple questions, so I'm going to start with this one. I think I'm going to start with whoever wants. Yeah, Sumon. If all the adults get vaccinated, what's the chance for the virus to cause severe illness in kids? Actually, that's a hard one. Is it?
You cut off at the end there. Say it again.
Okay. It says, if all adults get vaccinated, what is the chance for the virus to adapt and cause severe illness in kids? That's the first part. And how would this affect schools' mask wearing for kids in September?
Wow.
I put it in the
text that's box. Yours. That's yours.
Yeah, that's mine. Yeah. Okay. Listen, so I think if you look at virus biology, whenever we hear the word mutant, I've actually mentioned this when I've done articles, that people think of the X-Men, right? People think of you get this, yeah, exactly. Like you just get this radioactivity, you're get this crazy new strength or whatever. And I think that we have to remember that mutations absolutely can sometimes do something that helps the fitness of the virus. A lot of the time it actually hurts the virus and makes it less fit. And the more a virus mutates, that happens, right? So I think the chance of something suddenly becoming more virulent to kids also doesn't make sense because you don't want to be virulent as a virus. You want to be more transmissible, but more calm, so you can find more hope. That's what happens, by the way. There's a guy named, what's his name? Nick Christakis, I think. He talks about the history of pandemics, and he talks about pandemic virology, and you can actually see that happening. Very interesting podcast he talks about. So the long and short of it is, I think it's very unlikely, especially in this season. And I think that at some point masks will be there because people are afraid, but they will melt away eventually. Yeah.
I hope. Yeah. Yeah.
I like seeing your face.
Yeah. No,
Not Zain, yours.
Well, yeah, mine. No one wants to see that. I can wear a mask for a while. It's fine.
But no, this is a pretty group. You're gonna want to get that mask off, yo. So,
yeah, exactly.
So if apparently we're all going to get vaccinated by September, what's the point of Johnson & Johnson vaccine arriving in September? Is it true it's arriving in September?
The contract is supposed to be filled by September.
Yeah.
Again, there is some truth to this in the sense that obviously there's a big supply chain. The U.S. is going to hold on to its own, and so you really have one manufacturer. I think somewhere in the EU, where it probably is going to be redirected into the EU in significant amounts. But even, you know what, even if we get 500,000 doses, we get a small allocation, that's a very powerful vaccine for particular settings, right? If you take that up to a indigenous colony, if you put that in emergency rooms and vaccinate your scarcely housed individuals when they show up, there's a lot of places where you can put even a small amount of that Johnson & Johnson vaccine. So I agree. I mean, if it comes late, so be it. We still probably will need it for some point in time. You might even need it for things like boosters for the South African variant, because that one actually works as a one that's effective against the variant that was first described in South Africa. But again, even if you get a small allotment of doses, that still can do profound things being a single dose regimen. So I think in that sense, the other part is I think the U.S. will get through their vaccine strategy a whole lot quicker than we will, and so we may be able to tap into their supply hopefully come June or July when they are kind of done with Johnson & Johnson moving forward.
Perfect. Here is there's a good question. The last question is a good one. I'm going to just frame this one, Sumon, as how anxious are you about kids in school? So the question relates to kids wearing masks, whether they need them or not. But and this could be both of y'all pipe in, but in terms of there's the data out there in regards to our schools a major source of spread, the data for kids giving it to parents versus vice versa. Like, where do you... How worried are you about the school situation? And then, but at the same time, asking this kids wearing masks at school question as well.
Yeah, so I think that obviously the problem with this discussion is it's quite polarized, right? I really try to stay with what the literature is showing us. I think that I always have to start with saying that there is definitely transmission that happens in school. Yes, there are cases in schools, and yes, there are situations where kids can bring cases back to their parents. There's no doubt about that. I think that what maybe the people that are worried about schools take exception with when people kind of talk against that is not so much that that's not happening in schools, is that a driver of transmission? And I think what we see is that when you look, and not just in Canada, when you look at other parts of the world, you see transmission chains coming into school and they stop. The school is not actually what's amplifying what's happening in the community, but what I've termed is my kind of not so creative term, but the occupational to household transmission chain. The one where you get occupational. I see this every day on the ward. I'll give you a great example is Canada Post. So many people that are either at Canada Post or they're a family member of someone at Canada Post in Mississauga, that big processing facility. You had a case come in and then it explodes in a household, right? That's a driver of transmission. That's something that keeps things going, right? Whereas what I see with schools is that schools, there's cases, but then if you look at the cases, there's whatever there was. I don't even know, 400 cases, but there's if you look at where they are, there's 2 cases in each school. There's 1 or 2 schools that have 7 and the rest of them have 1 or 2. And then the second thing people say is, well, maybe there are cases you're not picking up. And you're absolutely right. Those are probably there, but they're not necessarily kind of going back into the community and driving what's happening there. And that's what I think the issue is with schools. So I think that if you look at the risks and benefits of what happens with COVID and what happens with kids not being in school and having that interaction with kids and that development, I think that we've robbed many kids of a year's worth of, especially, I think, wasn't it in California, they just opened schools. It was after like a year.
There's a ton of places in the States that are still not open, actually.
They're still not open, right?
Yeah.
And I think just think about that, like as a kid, missing your entire grade 4 year. And just how different you were from the beginning of grade 4 to the end of grade 4. All I'm saying is I think that there's costs that we have to consider. And I think when you weigh everything, keeping kids in school was the way to go. And masks, fine. I think that's a fine price to pay, but I think that they will be coming off at some point this year.
Cool. Unless, Zain, you felt strongly about adding something, just let me know.
No,
They love
Sumon
talking
got
about
it,
schools.
I think. I hate schools. No, I mean, it's polarizing, right? And I think people want to look at the data. There's different sets. It's not an answered question, but again, I think you have to put everything on the table, including societal benefits on top of it, right? It's not just COVID. It's a number of different things going in, and again, I am absolutely for things that keep schools safe as part of that and keep transmissions low into the communities. I think masks are not an unreasonable solution in that context.
For sure. I guess this will go to Zain. Do you think there will be tough time convincing the younger age groups between, say, 18 and early 20s to get vaccinated?
Awesome question.
Yeah, I mean, it's a great question, I don't, that's a tough to reach population, right? You have to communicate on different levels. You have to get better incentives. You're not putting people at personal risk. I mean, we know from things like STI health, you really work on risk mitigation in that population as compared to abstinence or kind of extreme measures in that sense. So it is a hard population to reach. I think you can start now, right? Like this is not that'll be July, they'll be fine. You got to start that now, right? You got to get them excited, entertained, and wanting and demanding and answering their questions and making them feel appropriate. I do
have
think
a vaccination center, this is like a DJ. That would
yeah,
or
exactly.
TikTok.
Exactly. Food trucks outside.
Good,
like,
actually.
Exactly.
Well, see, the funny thing is that would be good for our, Kwadwo and I were old. Zain, you're a bit younger than us, but I think that would be good for us. I think, what do kids do now? They TikTok and.
What I don't know what the kids, where my age is coming through. You listen to the music these days, my God, I can't deal with it. I legit can't deal with what's going on. Like, I never thought I'd be that old guy, that parent or whatever, but I hear this shit and I'm just like, I don't feel it. I don't see it.
I try.
What's the beat? You know what I'm saying? But
I
think, sorry, go ahead.
Yeah.
Go ahead.
No, it'll be tough. But at the end of the day, and this is where the controversial issue with passports comes in, you may tie things like going back to university or going to college or going to a congregate setting to the ability to get vaccinated, right? And I'm working with my own university to what a return to school plan looks like, and yeah, I mean, I think all of these plans involve a good amount of vaccine in that age group. And so I think, that might be the last incentive, but it doesn't mean that you can't positively message and let people make that decision on their own. It just means that, again, some of those high risk things that have been left off the table may not be there. I will say this is another good example where Johnson & Johnson is actually probably not a big deal in that sense, right? You get 18 to 20-year-olds, they're transient, they're all over the place. Give them a dose, be done with it, and they've had as much protection as they need for now, essentially going forward.
You actually linked to that Waterloo article, because I've heard this on other podcasts before, actually, about the strategy of actually vaccinating our younger population, because that's a lot of transmission is happening through them, and they come and visit their parents on whatever XYZ occasion, and that could be a way of mitigating spread, which I thought it was actually a conversation we haven't talked about much at all, but it's an interesting conversation regardless. You know what I mean?
Yeah, and the Waterloo data suggests you knock down deaths 33% by immunizing people 20 to 40 years old, right? As compared to immunizing older people, where you knock down deaths a lot less, which is remarkable in that sense, right?
Wow. Yeah, it's really good, like food for thought. But just to reinforce what you're saying about this one, when we had Heidi Tvorok on, and she's talking about how Senegal was doing creative ways to engage their youth, like they had murals, they had like hip hop artists busting out tracks about how to stay safe. I was like, yeah, man. I don't need Ford telling me how to throw down. You know what I mean? Like this is just I thought it was just genius. Okay. I really like this question. With the CDC guidelines talking about allowing socialization for fully vaccinated Americans, what guidelines make sense for Canadian after one dose if our second doses are delayed? Wow. Any takers on that bad boy?
That's a tough question.
Okay,
that's a brilliant question. Actually,
here's the thing: is that I think what as Zain would say, the elephant in the room is, I think one reluctance of the Canadian public health messaging has been is that if you give any concession to whatever, like relaxing this or doing that, I've heard this over and over and over again. People are just going to go crazy and just act recklessly. And we're just going to, and what I've seen a lot is that we're going to lose all the gains that we've made. That I've heard that expression a lot. Right. And I think that aside from moralizing, I don't think that's completely accurate. I do think that it's important that when people get vaccinated, they have to know that it's leading to something. Right. You can't say that. We've already been hearing it. Like, if you get vaccinated, you still have to wear a mask. I agree with that. But I think that you should also add to that look, getting vaccinated, you're one step closer to being with other people. It's a very interesting point that now that we are spreading things out, what does that mean? And I think that we have to start talking about it. We have to start talking about what people can do, because once you start to see that hospitalizations are dropping, things are really, really improving in the right direction, and to a point that even if you do see a reversal, it's not going to happen quickly, right? I think that we really need to start talking about what we can do. And Zain's mentioned this a bunch of times, is that give people safe ways to do things.
Oh my God!
I think.
I don't mean to go off on a soapbox, but this has been one of the biggest lacking messages throughout this pandemic. Imagine empowering people and saying, "This is how you do this safely." You're gonna gather at Christmas, just imagine, because they were allowed to gather Christmas Day, right? But instead, I was saying, if you had a at-risk family member, think about it. Number one. Number two, if you could do anything outside. Really, the risk of anything outside, I'm sorry, I don't care what people are saying, but it's negligible. I'm sorry.
Negligible.
I from the data that I've seen, I really think outside is safe. Really giving people the tools to and empower them and say what you can do. Focus on what you can do. This would be such a different lens, and I think people would just even in terms of mental illness and hope, you would see a different you would just see a more positive slant on these things, and I think it would impact many lives of Canadians. I think we missed the boat on that. I really think we did, especially when we look at summer months or times where things were in a lull. I just had to say that because I think it was an opportunity missed in so many ways. Okay, next, this one's for Zain. When do you think we'll stop testing all the kids for their one symptom? When do you think we'll?
It's like one runny nose that gets a kid kicked out, which unfortunately, I can tell you, my daughter has had 7 swabs. Seven?
Wow.
Jesus Christ.
Yeah. So 80% legit, but 20% were a little bit overcalls. So, God bless that daycare. They love her. And so be it. She's tripled me in terms of swabs, which is pretty ridiculous. But anyways, So, I mean, I feel this every day personally with frustration, right? It's interesting. If you look at COVID, again, we were talking about influenza, right? Like I get lab reports from our virology lab. There's like 2 rhinovirus cases and the rest are all COVIDs, right? So at the end of the day, the etiology of a runny nose right now is much more likely COVID than anything else. And I think we have to recognize that probably is, what's circulating. It's not, in September and when rhinovirus, enterovirus season starts, that late summer, early fall, it probably is going to be rhinovirus. And that's when you start making these value judgments to say, okay, is there a lot more of something circulating in the community? How much COVID is circulating in the community? Is that really reasonable? And I think as well to what Sumon had said, when again, this becomes a very community-centered disease, when this becomes a disease where again, hospitalizations and deaths aren't a consequence, and it really, the whole concept of getting tested in the community is probably going to start falling by the wayside, right? It is going to be, your kid has symptoms, stay away from school for a couple of days, let them recover, and then bring them back in that sense. And again, with a vaccinated population, I don't think we're going to, care if kids bring things back from daycare. I mean, I think, Sumon, you're a young dad, like, and you as well, Kwadwo. Your kids brought crap back from daycare, right? Like, you were sick, for probably months and months and months. Yeah, exactly. Right. Like that was just a normal entity of life. Right. And so when COVID is dealt with, when the parents have vaccines in hand, is it going to be a big deal when your kids bring something back from daycare? If they're fine with it and you're fine with it, it's like life again in that sense.
I cannot wait for the day. I cannot wait for
I can't either.
I think the last couple questions here. Actually, I got this one I saw in one of the text box, and I think it's a good one. Any thoughts on the eye protection?
Zain,
yeah,
you take this one. You're really good. You're much better at eye protection.
So I mean, eye protection is one of these things. Like, I mean, I think there's some data to suggest it, right? There was a good study that was done in contact tracers in India, where if they were wearing eye protection, the risk of getting COVID-19, in India, they were doing like in-house contact tracing, like door-to-door knocking, and so you were with COVID patients and contacts. And the ones that wore eye protection versus not had a differential rate of COVID in that sense. The whole concept of eye protection comes down to risk, right? So are you around people where there's a high risk of unidentified COVID in that sense? And are you around, is there a high enough risk with masking that you're going to get some aerosolization or viral shedding outside of, masks on either entity in that sense? I think many institutions have kind of flexed to universal eye protection in that sense, and in hospitals, many restaurants put them on their waiters and waitresses. Even my kids' daycare, the teachers wear them all day in that sense. I think if you're dealing with a population where their ability to wear a mask is probably compromised, it's not a bad intervention to add on top as an extra layer of protection. But if you're dealing with an environment where people can probably wear good quality masks effectively right now, then the eye protection piece is pretty little yield on top of that. And add to that, you're distancing and you're doing everything else appropriately, right? Like it's a 1% change or 2% change. In a high risk environment, it makes sense. And again, when you're dealing with little kids where they can't wear a mask, it makes sense to give the user as much protection as possible. But I think again, as you start seeing vaccines, as you start seeing people be more comfortable, I think it's going to be one of these things that eventually does fall down in that sense, or gets left to the clinical setting more than just the regular world setting in that sense.
Oh, for real. Okay. I got 2 more questions. One, Sumon, with 1 dose, say many Canadians have their single dose of whatever vaccine, will we still be restricted with travel? Do you see that still happening?
To be honest with you, I think that it depends on what point of the pandemic that we're in. To be honest with you, like right now, all these travel restrictions, I mean, they were initially put in place somewhat for show, although I am a person who thinks that they are doing something, right? Just deterring travel. I kind of like that idea for right now, but that's going to fall to the wayside at some point relatively soon. So I don't think that whether you have one or two vaccines is going to make a difference for that. I think it's going to be other factors that take that away. I guess this kind of loosely relates to vaccine passports, and we've talked about them. Vaccine passports, I think that for travel, I don't know, we do have it for certain countries, right? Where you have yellow fever, the Hajj meningococcal vaccine, those kind of things. You have them for schools. Although here's something interesting. I grew up in Ontario. Vaccination is a prerequisite for school, right? But it's not the case in other places in Canada. New Brunswick requires measles vaccination. Manitoba does. And the rest of them don't require necessarily immunization to get into school.
I didn't even know the Ontario one was mandatory.
Yeah. Well, you need to, it's like an opt out or whatever. But the point that I'm saying is that it exists. But I think that where I think it makes sense is if, let's say if you're a country that has a fragile healthcare system, you have maybe the vaccination is not quite up yet, but you need tourism as part of your economy. It makes sense to have a vaccine passport in that situation. But anyway, so I don't know, but I don't think that it's going to restrict us in Canada, but it might restrict where you're going as a destination.
Yeah. I must say, I gotta, one thing, I got asked this question about, can you hug your grandparents after you get vaccinated and stuff I just think we got to move forward if we're getting people vaccinated. They have to have a goal. There's a purpose of this thing. You know what I mean? And we got to get back to being human beings, contact, connection, community, whether it's travel, whether it's, seeing grandma, hugging your grandkids, if you can't do it after vaccines, and yes, this is not zero risk, but name me something in society that's zero risk. You know what I'm saying?
Yeah.
And what's a weird thing right now, right? Our biggest travel partner is the US. And there's going to be a point when many individuals in the US will be way more vaccinated. The rates will fall down in the US. Yep. And, as much as we've been standing here on our side of the border saying, stay on your side of the border, there's going to be a point where the US is going to be like, well, I'm actually lower risk than you are in Canada,
no,
right?
100%.
And so what are we going to do about travel then, right? Because by that, a fully vaccinated 2-dose Pfizer person from the United States coming to Canada who wants to do business or who's doing for tourism, wants to go to Whistler, whatever, that's actually a low risk interaction, right? You might want to test them on the border to make sure that they're not shedding COVID and that type of thing. But at that point, that person's probably the lowest risk person to be coming into Canada. Your fellow Canadians are probably higher risk than that person that wants to come in over border in that sense, right? And so, again, this is the wonky world we're dealing with. We've been looking at the US with disdain in terms of what's been going on there. There's going to be a point where their vaccines catch up and they're going to be looking at us and saying, well, I want to come over. I'm protected, but I don't know about you guys up here, right?
They'll close their border to us.
The American, oh my goodness.
Kwadwo, can I do something?
After
the last question. Can I ask you a question at the end?
Ask it right now.
Okay.
Ask it right now.
So we're close to the end, that light of the tunnel. What do you miss the most? It's not family, hugging family. Okay, we get that. Okay, I'm talking about a material, almost like a leisure thing. What do you miss the most that you haven't been able to do in the last year that you're going to do when it's all good?
My boys, we'd get our families together, the guys that we would go play football, we call our football crew. There's about 5 or 6 of us. We'd go to a football game every year, but on a regular basis, we'd have a barbecue, bring all the families in one house.
Amazing.
Just let the kids be kids, smiling. We'd be, having our beer. We would be, talking football, talking sports. We're all physicians too, so there's a little bit of shop talk. The wifeys are good friends, and we haven't done that in over a year. My boys, like a couple of them that I know well, like I only see them at work now. I miss seeing their kids. I feel like we've missed out on some of the times them growing up. But I must say I've been blessed that in some ways a lot of things that are important to me have come back. Like my gym's opened up, but I'm not. It's hard to book Movati, man. You got to help me out, dog. But I'm back to playing hockey. So like my kind of stress release from an ICU week culture is back. But I love that question. Actually, what about you guys? It's better than my question.
Sumon, what's
okay,
yours?
so of course, I mean, I haven't seen my parents in
I should say that
August,
too.
whatever that was.
I haven't seen mom. Yeah, you're right.
Although my dad got his first dose of Pfizer on Friday.
Oh, nice.
So I'm going to see them soon. So all that stuff, listen, all the stuff, hug whoever. Okay, that's great. What I want to do is go to a restaurant with my family. I want to sit at a table and just eat the whole night around people that I have no idea who they are. I just want people to be walking in. I want to bump into a person going to the bathroom. I just want people that I don't know, that I'm not afraid to be close to, within reason. Like, I don't like people that much. I'm just saying that, just like people just being in, and I'm talking about nothing fancy. Like, I'm talking about, you guys ever been to Zain Earls at Square One?
Yeah. Of course,
going there and just sitting with people walking. That's what I miss, and I can't wait to do.
That's amazing, actually. Concerts too. Now. Concerts. Imagine seeing a concert.
Yeah.
Or sporting event.
I was watching. You saw that gift that I gave you, the Jose Bautista's bat flip home run. I was there, and I can't.
You were at that game?
I was at that.
I would have taken off my shirt straight up.
Yeah,
it would have been weird. I was just like, I'm going to take off my shirt. That's how excited I am.
It is. Can you imagine that? Zain, you're a huge Raptors fan, right? Can you imagine right now just being at a Raptors game? It would be so amazing.
Oh, Game 7 was it Game 7 against?
I was there.
You were in that game?
I was there.
Quadruple bounce.
Yeah, God. I was there. My heart stopped. It was the like. I thought
it was like the most magical event. Like, I just so happened to like Kathy and I, my wife and I, we just turned on at that point. And I'm like, in motion, like that shot was so hard over the 7 foot. You know what I mean?
Oh, we were like, okay, overtime. It was getting late. I'm like, oh God, this lead, and it was just like went in. Like, it was surreal, right? Like, okay, so Raptors game number 1. That is like my big thing. I've never seen LeBron play. I had tickets to the Lakers literally a week before everything went to hell, and I didn't get to go. I'm going to go see LeBron play before I am done with life here, okay? Before he's done with his career. And the one thing I miss, and again, like, I think Sumon and I both agree on this, is like, we do a lot of media. I'm happy to fade into the background and go back to my day-to-day projects, right? Like, I have a lot of global health projects that went on hold, and I can tell you the time I spend outside of Canada doing global health work, it rebalances you. And I think it really gives you that perspective and gets you away from this bubble and this echo chamber of what we are in Canada. Like, we are, it gives you that global perspective of how small we are in the world in that sense, right? And I think it's one of those things where the longer it's been not doing it, the harder it's been to actually get that rebalancing moment that often just brings me back to work, with that much more passion to get back to it, and that much more passion for efficiency optimization and doing things that affect people rather than necessarily doing things that affect processes in that sense.
Oh man. And because I'll tell you too, like, even in our little text group, you COVID can be infuriating. You know what I mean? Like people's attitude, people's how polarizing some issues have become. The fact that we can't have honest dialogue about so many things, like the idea of even seasonality at one point was taboo topic. But I want to say this, crew, before we bounce off, is that I know the media stuff is draining, and I often get people ask, like, why do you do it? Like, is it? And I gotta tell you, the idea of being able to have that balanced discussion in such a topic that has been so polarizing. The idea that we can reduce so many people's fears, because people don't really have a good appreciation of the risk. Like, you know what I mean? Like that often, I still see people running, on the canal or whatever, and when they walk by, they're covering their mouths and worried that they're gonna get COVID on the fly. I'm like, son, you gotta work a lot harder to get COVID, son. Like, this ain't gonna work. But we can't underemphasize the work that we're doing to, as Sumon mentioned, like really shifting that narrative and having that slant to positivity and hope for this thing. Like, it's important stuff that we're doing. So, I mean, I'm still going. I know you guys are going to still be hustling, but I'm still hustling, and I think it's amazing that we even are privileged enough to be able to do that, man. Like, it is a bit of a privilege to be able to step up and help dictate things. But gents, as usual, Quadcast Nation, we said we'd bring it, and we brought it. You know what I mean? We talk vaccines. We're talking, okay. I need Oiler Nation somewhere in there.
Get your Oilers.
For those that are just listening, Sumon's wearing his Habs shirt, which I don't mind. I don't mind the Habs. If it was Leafs, I would burn my screen. But yeah, we talked vaccines. We talked AstraZeneca. We talked, third wave. We talked variants. And at the end of the day, people, there is hope. And I think this is what I think you guys want to hang on to. There is hope with us Canadians getting more and more vaccinated. And I'll emphasize this one more time. You get offered something, you take it. Okay, this is I don't care what you're reading about efficacy and so forth. The vaccines are amazing. They truly are amazing, and I hope that message came across. I want to thank Zain. I want to thank Sumon. I want to thank Julia for screening the questions, and all the work that you do. It means a ton. And Quadcast Nation, thanks for listening, guys. We're going to continue to help dictate the narrative and change that boogie, yo. Changing the boogie. All right. Peace.